Kim, we're not live right now, right?
I don't think so.
Yes, we are.
Okay.
All right.
I get started now. Hello, everyone. Thank you for joining us today for this session of the Susan Samueli Integrative Health Institute's Research Webinar Series. My name is Dr. Kim Hecht. I am the Medical Director of Inpatient and Ambulatory Services at the UCI Susan Samueli Integrative Health Institute. I'm happy to be moderating this session. Before we start, I want to review a few Zoom housekeeping items. This session is being recorded. We will send all registrants the link to the recording, and we will post the link on the event webpage. Everyone will remain mute to limit distractions, and please communicate with us, including any questions in the Q&A feature on the bottom of your screen. We will hold a Q&A at the end of the presentation. The Samueli Institute is committed to whole person health research, education, and clinical care. Our interdisciplinary researchers are dedicated to exploring the science of disease prevention and treatment. We bring this series to you to share the promising integrative health research that is occurring throughout the Institute's pilot study grants and Samueli Scholar Awards. To date, the Institute has supported 25 investigations with the potential to enhance our understanding of integrative practices. For more information, please visit our website at ssihi.uci.edu. Our speaker today is Dr. Robert McCarron. Dr. McCarron completed a dual residency in internal medicine and psychiatry at Rush University and received board certification in psychiatry, psychosomatic medicine, and internal medicine. While on faculty at the University of California, Davis and Irvine Schools of Medicine, he started the only 2 California-based combined internal medicine psychiatry residency programs. In these roles, he received grant support to create and implement a med psych curriculum that can be used in the public mental health system by psychiatry residency training programs. Dr. McCarron is the founding director for the UC Irvine Train New Trainers, TNT, Primary Care Psychiatry Fellowship, and the TNT PC Training and Education in Addiction Medicine Team Fellowship, which are both one-year programs designed to train primary care providers in the essentials of adult psychiatry, pediatric psychiatry, and SUD behavioral health. Dr. McCarron also serves as professor, Department of Psychiatry and Behavioral Medicine, and Associate Dean of Continuing Medical Educations at UC Irvine. He is also the Director of Education for the UCI Susan Samueli Integrative Health Institute, and he serves on the ACGME Residency Review Committee for Psychiatry and is Medical Director for MindOC. He's a very busy guy. Dr. McCarron is a California National Alliance on Mental Illness board member as well. Please join me in welcoming Dr. McCarron.
Hey, thanks, Kim. Appreciate that. It's good to be with all of you. And today I wanted to talk a little bit about something that I think has been an ongoing problem in our society and in our country, and hopefully looking for ways in which we can make a difference here at the Susan Samueli Integrative Health Institute and the UCI School of Medicine. And so we'll be talking about transforming training in primary care towards better access and optimization of care in the area of integrative psychiatry. A couple disclosures. A deputy editor for Up to Date in the area of psychiatry, and I'll be talking a little bit about psychiatry. Also, 2 textbooks that we'll have some slides from those 2 textbooks as well. And then, of course, as Kim said, I'm director of the Trainee Trainers Primary Care Fellowships, and that will also be a topic of discussion. But I'd like to lay out, and this will be sort of, I guess, if you will, the difficult part of the talk for, I think, all of us, is laying out the state of mental health care and delivery in this country. It's not good. To put it simply, it's not good, but I think it's important to show some of those details, to discuss how it's not good and maybe why it's not good. And then we'll also talk about who's delivering this care, who's delivering, the care for those who are struggling, suffering with depression, anxiety, unexplained pain complaints, substance use disorders, and other common psychiatric disorders. And then we want to talk about a model, an educational model that's specifically designed to expand access, to improve treatment for common psychiatric disorders, and interestingly, not for psychiatrists or psychologists. We'll also talk a little bit about how it's important to integrate whole person or integrative care into this curriculum, which I also think is transformative, by the way. And so we'll talk a little bit about that, and then we'll prove how it might be transformative. We'll talk about outcomes. We'll talk about some of the changes in practice patterns among those who have participated in this Train New Trainers Primary Care Psychiatry Fellowships. So let's first then talk about some of the specifics on how this is not good, right? So many of us are going to struggle during our lifetime, during this year, with some psychiatric disorder, which will cause us mental anguish and discomfort. I refer to psychiatric conditions as pain. It's pain. There's physical pain, there's emotional pain, some may deal with spiritual pain. Just so happens that this type of pain is emotional in nature. And so the lifetime prevalence for psychiatric disorders for most of us in the United States is about half. Half of us will have some type of psychiatric disorder. 1 in 3 will suffer or struggle with a substance use disorder. Okay, and during the height of the pandemic, just to show this data from the CDC, 40% of adults during this pandemic were struggling with mental illness. That number has not gone down a whole lot since the pandemic has ended. And the breakdown for that is anxiety and depression at about 30% of those affected, and then increased substance use at 13%, and serious consideration of suicide, about 10% of those. Again, 40% during the height of the pandemic. That hasn't changed a lot, struggling with mental illness. Anxiety and depression are the 2 most prevalent disorders, and the first and second, respectively, causes of disability worldwide due to a mental condition. Depression in itself is one of the top reasons for disability or causes for disability, again, worldwide as well. And so, unfortunately, it's tricky though, because those who have anxiety and those who have depression, very common disorders, and often commingled with pain, physical pain as well. Many of those folks are not getting the care that they need. They might be misdiagnosed. We can see here that about 40% of individuals with a specific anxiety disorder receive a chunk of those folks are not even correctly diagnosed. So, and we'll talk about why that is. We'll talk about why that is. If we look at kids, UCLA Center of Health Policy Research, 2021, again, during the height of the pandemic, released some data that was really quite concerning. Nearly 1 in 3 adolescents in California reported serious psychological distress. If you look at the prevalence of asthma in kids, young kids all the way up to 17, the prevalence is about 13%. Well, in that same age group, the prevalence of any mental health diagnosis is about 50%. And again, I think oftentimes we're more likely to talk about asthma or give someone an inhaler for asthma, and less likely to talk or even recognize in early form certain psychiatric conditions that our kids are struggling with as well. Suicide is the second leading cause of death among this age group as well. Not a good thing. Okay, and I'm just laying the stage for why I think it's important for UCI and the Susan Samueli Integrative Health Institute to take the lead on how we can transform, change things, and move the care in the right direction for those who need it the most. And so substance use is really likely to start before adulthood. 1 in 8 high school students will have some type of significant diagnosable substance use disorder. A quarter of individuals in this age group will continue to use drugs and be addicted to substances, physiologically addicted, once they used substances before the age of 18. 1 in 5 adolescents are using cannabis, right? And I think probably more so in certain states that allow it recreationally. And again, during the COVID pandemic, about 50% of adolescents use a substance at least one time. The state of drug use is, I would say, emergent at this point. Data going back again, looking at the pandemic time period, showed that about 100,000 Americans died by way of drug overdose. That's gone down a tiny bit just very recently in looking at 2023. Not much though. And this translates to about 250 to 275 deaths per day on average, and which is an increase if you look back to several years prior, a significant increase. Fentanyl, methadone are really often the culprit, and both of which have, I would say, a higher likelihood to kill, to cause arrhythmias and respiratory depression. But kids are dying from this, not just adults. Alcohol, the #1 misused and misused substance among adults in the United States of America. We see 1 in 3 adults will meet the criteria for an alcohol use disorder during their lifetime. It's a big number. Alcohol resulting in about 80 to 90,000 deaths per year. And unfortunately, we see this as a trend for those who have significant psychiatric issues. A very small percentage, about 4% of those struggling with substance use disorders, are really even able to get treatment. It's hard to find treatment for psychiatric conditions in most parts of this country. Suicide among the top 10 causes of death for all ages, leading cause of death for those between the ages of 15 to 24. And the rates per CDC have increased significantly, about 40% over the last several years. It's about 1 death every 10 or 11 minutes in this country. Again, a lot of despair, a lot of suffering, a lot of pain, emotional pain as well. Now, let's talk about availability, right? Availability of care for those who may need it the most. And we'll point out a little bit later that those who have severe and persistent mental illness are uniquely vulnerable for a multitude of reasons. One is they're not getting care. 2, they're not getting preventive or primary care. And 3, they're dying a lot earlier relative to those who don't have severe and persistent psychiatric conditions. This is basically just an overview of the Health Resources and Services Administration, or HRSA, looking at health professional shortage areas, or HPSA areas in mental health. And we can see that the beige areas, or the light gray areas, are good. Those are good areas. The blue, not so good. Dark blue, really bad. And you can see here, there's not a lot of light gray, right? Most of this is covered with dark blue, light blue, and basically showing that throughout this country, there are only small pockets geographically that allow for, provide adequate behavioral health care delivery. Most areas simply do not. Now, here's the other thing. We don't have enough psychiatrists. We just don't. So half of psychiatrists are over the age of 55 and looking really more towards retirement. It's unlikely in the next 20 years, or probably more, that we'll even come close to having enough psychiatrists. Here you see the age distribution of psychiatrists here in California. And this is looking at data in 2018-19, but mirrors recent data as well. Developing a handful of new psychiatric residency programs is not going to be an answer at all. And that's even hard to do. And so really trying to find a way in which we can significantly, meaningfully expand access to care for those who are most vulnerable and those in most need is going to be really, really important for us to look at and to figure out a plan as well. So bottom line, the big picture is the de facto mental health care system is not the psychiatrist's office or the psychologist's office or the social worker's office or the therapist's office or the behavioral health trained provider or clinician office. It's not. It's actually the office of those who have not been trained extensively on how to deliver this care, how to deliver care for those who have psychiatric conditions, common psychiatric conditions, or again, emotional pain. So the primary care setting is the setting where we see most of this care delivered, the diagnosis being made or not made correctly, and the treatment plans being developed as well. So about 70% of all behavioral health care delivery is delivered in that setting, in the primary care setting, not in a setting where we see those who have behavioral health training present. On any given day in a primary care setting, in a primary care office, what we see is about 40 to 50% of all those patients seen are struggling with emotional pain, right? With psychiatric conditions, most often depression, anxiety, for example, which translate into decreased functional sort of disposition, right? Decreased ability to work effectively, decreased ability to support a family, decreased ability to be available emotionally to a family. And those who are struggling with depression and anxiety are not functioning at their highest level. And so that is a problem for society, not just for the individual. It's a problem for their family, their friends, not just the individual. And so 2/3 of PCPs aren't able to effectively refer patients to mental health specialists for a myriad of reasons, mainly lack of availability. Now, when they are able to send someone, about half the time patients aren't able to make it to that referral, and there's a lot of reasons for that. It could be stigma against mental illness, low funds, financial resources to do that, barriers in language, a paucity of psychiatrists, and other reasons. So we're really set up here with a system where we have a lack of providers or clinicians who can deliver the care for those struggling with behavioral health issues. Those who are delivering the care, and you can see in this slide, it's about 40% of all of those who are getting treatment I'm sorry, let me rephrase that. About 40% of those who need treatment are getting some type of treatment, right? Which means about 60% are not. They're suffering at home. So of those 40%, we see that about 60% of them are getting the diagnosis and the treatment planning in the primary care setting or general medical setting, and the remainder, about 40%, in the behavioral health setting. This is not ideal. It's not ideal because those who are in the primary care setting have had very, very limited training on how to diagnose common psychiatric conditions and how to even initiate treatment, let alone looking at treatment for those who maybe failed the first round of an antidepressant or anxiolytic. So this is a big issue: lack of training, lack of availability, which translates to suffering for those who are most vulnerable, those who are suffering, who need care the most. About 40% of psychiatrists see cash-only patients. Now, that lowers the availability right there of the already limited number of psychiatrists that we have in this country. And let me point out that it doesn't mean psychiatrists are greedy and they want cash only. A lot of this is related to the fact that psychiatrists are still struggling to get parity for the care that they're delivering relative to other physicians. For example, insurance companies may not be as likely to to cover the costs of that care. And so it's constantly a struggle and something that we continue to work on from an advocacy standpoint, both statewide and nationally. So we've talked about the fact that depression is up there as a leading cause of disability. We've talked about the fact that suicide is a huge problem. And the fact that a bunch of those struggling with depression are not diagnosed. Some who are diagnosed with depression don't have depression. 80% of antidepressants are prescribed by non-psychiatrists. Many of those folks did not receive significant or even adequate training during their time in medical school and residency and beyond. So more than half of primary care patients on antidepressants don't even meet the criteria for depression. There was a study done a while back, a survey of internal medicine residents showing that only a third of them felt comfortable treating depression. If you add on some anxiety, maybe a little bit of a personality disorder and substance use disorders, as well as some general medical issues in the span of a follow-up visit of 20 minutes, that's hard, that's difficult. It's not only difficult for the clinician or the doctor, but it's difficult for the patient and their family as well. So all of this leads to, and I would say, a heightened sense of vulnerability, a heightened sense of need for so many patients struggling with these common psychiatric conditions. It also has a negative effect for our society and for our emergency rooms. When I'm on call, I often see patients who are there for many days, kids sometimes more than a week, sitting in the same room with no window, with food that's not so good, and in need of care, in need of help, and suffering with emotional pain, significant, profound emotional pain. My wife told me that I need to put a picture of me here, so that's what this is here. This poor guy's trying to get into this Midvale School for Gifted, and he's pushing instead of pulling, which shows the importance, I think, of understanding, of needing to get transformative education and training. What I mean by transformative education is education that's going to result in a change, a measurable and significant change in how we deliver care, right? It has to be measurable. It has to be high impact as well. And so one of the things that I wanted to talk a little bit about today is some of the stuff that we've done here at UCI, and also looking for the future here as well at educational initiatives that I think are going to be very high impact at the Susan Samueli Integrative Health Institute. So first, looking at 3 programs that are specifically and strategically designed to expand, to grow, and to optimize access to care for those who have significant psychiatric issues. The first is the Train New Trainers, or TNT, Primary Care Psychiatry Fellowship. The second is the Train New Trainers Child and Adolescent Psychiatry Fellowship, or TNT CAP. And then most recently, the Train New Trainers Primary Care Training and Education in Addiction Medicine, or TNT PC Team Fellowship. And so why did we develop these fellowships, these somewhat unique, a little bit out of the box fellowships? And I think the first reason we did this is we have found that those struggling with behavioral health conditions are underserved, unserved, marginalized, and vulnerable. And so coming up with a solution that squarely is going to address that was important for us and remains to be a top priority. Also, the TNT program, and I think this is also congruent with what we see in the spirit of integrative medicine, is looking at the importance of prevention and early intervention. Treating someone who has late-stage psychosis, for example, and is at high risk for suicide is ideally not the best time to be initiating treatment. Treating someone who's got an ejection fraction of 20% with really bad heart failure, that's not the time to really try and initiate care. If we can get to folks early in the stage of the disease course, that's going to be better. It's going to be better for them with a better prognosis. The third reason we started the TNT Primary Care Fellowships is we have found the importance of of expanding this transformative training. And one way to do that is using the T&T approach to train new trainers. So we want to have an exponential transformative approach here, where we are not only training an individual to do their job as a physician in a better way each day with their patients, which is high impact, but we also want to make sure to train them how to train others within their clinic or region. And so it was important for us to make sure that we're setting up a system where we're training new trainers, right? And which is part of this. Some of the core components of the Train New Trainers Primary Care Fellowships include really focusing on quick and targeted information, right? How to do a quick and targeted exam in a short period of time, focusing on common psychiatric conditions, not all psychiatric conditions. If you want to learn about all psychiatric conditions and how to treat the most severe, challenging conditions that patients may have, then it's probably best to do a 4-year psychiatry residency program. But we're really trying to show PCPs, primary care providers and physicians, how to best deliver that care in their setting, in their busy primary care setting. So we're not training them to do things different or expanding the care that they already give. We're trying to help them do a better job at effectively or diagnosing and treating patients they're already seeing in that clinic. We're also showing them, when they should be referring to one of their mental health specialists. And also, like as I mentioned, using the T&T approach, we want to show them concretely how they can, during a busy clinic day, how they can help their colleagues and train them as well. This comes with CME as well as MOC, maintenance of certification credits. And then the other thing that's really important here is about 3.5, 4 years ago, we started the process of introducing whole person care to our fellows. Now about 1,200 in total, and we thought that was important to show there are different effective approaches that may not be mainstream to all psychiatrists in treating common psychiatric conditions. And of course, publishing our outcomes in peer-reviewed medical journals is going to be important to show that what we're doing is working, and to also continually improve on how we're teaching and how we're mentoring. So really, the Train Trainers curriculum is outlined in these main core components. The first is 2 case-based, web-based learning modules per month. These are usually outside of normal clinic hours, Pacific Standard Time. We have 2 intensive weekends, in-person sessions, learning sessions. The first is the very beginning of the fellowship, which is year-long, and the second is about halfway through, midpoint, which is more intensive, more hands-on, more triad, small group learning as well. And we also, in addition, have at least 1 hour of small group mentorship sessions where we have a faculty member who is usually multi-trained in, let's say, for example, family medicine and psychiatry, or internal medicine and psychiatry, or pediatrics psychiatry and child and adolescent psychiatry, working with a small group of our T&T fellows to go over topics, to go over cases. We also have open office hours to go over specific topics that may be of interest. Integrative medicine or whole person care is one of those topics. We feel strongly that including integrative medicine as a starting point for these fellows is important, not only to address the emotional pain, but oftentimes the physical pain that is, again, comorbid with the psychiatric conditions. And so lastly, we want to make sure that our training, our mentorship is ongoing after our fellows graduate. So our alumni receive career-long monthly mentorship, ongoing trainings, and open office hours for no additional tuition for the course of their career. These are some of the textbooks and handbooks and ebooks that we use. Working on 3rd edition right now, almost done with it. We have about 4 months to go. 30 chapters in total, and this textbook and handbook and ebook are really designed to train in the area of psychiatry for non-psychiatrists, so primary care-based psychiatry, also using a book looking at preventive medical care, but in the area of psychiatry. The reason we do this is simple. We know that those who struggle with significant psychiatric conditions like schizophrenia, for example, or schizoaffective disorder are more likely to die 20 to up to 30 years before those who don't have severe and persistent mental illness. And I think we're all in a position to try and decrease those numbers. It's very concerning to see that. We started with 35 fellows in 2016, and now we're at 268. We have 425 fellows total in the 3 fellowship programs. These are some of the topics that we covered just in the primary care psychiatry alone. I've highlighted some of them, including cultural psychiatry, substance use disorders, pain psychiatry, which is looking at the treatment of chronic pain, but also coupled with addressing emotional pain. We talk a lot about motivational interviewing and also provider wellness, as well as integrative health and whole person health as well. Our faculty are now about 50 total from all over the place. Again, most, if not all, are multi-board trained. This is our wonderful team in the School of Medicine who runs the show and makes everything work. Our research team here, who have done such an amazing job in preparing the outcomes that I'm going to be sharing with you over the next 15 or 20 minutes. This is one of our groups here from Cedars-Sinai a few years back, and a good group of folks interested in learning more about primary care psychiatry. Learners come from all over the globe now. You can see the concentration is mainly in California, but also the Midwest. And this year, many more in Colorado, for example, as well as Illinois. How do we do this? Well, we're able to partner with our community. And our community sees the need, which includes health plans, other academic institutions, other counties and cities, other states, and even other countries at this point. So these community partners will provide scholarships for the fellowship, so our learners are not having to pay out of pocket. I would say about 90% of our learners are receiving scholarships from these community partners. And about 85% of our fellows, our alumni, come from designated underserved areas, which means they're working with patients who also, of course, come from those areas. Excuse me. So one of our publications, I think this was in 2021, from the Journal of Continuing Education among health providers, looked at some of the early outcomes of our trainers primary care psychiatry fellowship. These are some of the demographics. I'll just point out that most of the people that we're training have been out in practice for 10 to 12 years, which is interesting. They're out there, and for 10 or 12 years, they've been struggling. How do I do this? I don't know how to do this. And so on average, about those who've been out for about 10 or 12 years are coming back and saying, I want to learn how to do this. I want to be better at diagnosing common psychiatric conditions and working with my patient to develop a treatment plan. Most of our learners are physicians. I would say about 75 to 80% or so. But we also do train nurse practitioners, physician assistants as well. Most are family medicine, followed by internal medicine. Just to kind of give you an overview, if we look at pre-assessment of knowledge and confidence in treating the patients who have psychiatric conditions, midpoint and post-fellowship, we can see here that the knowledge line has significantly and statistically increased from pre to post, as has the confidence to treat has increased during the course of the fellowship as well. If we look just at the knowledge score, and these are looking at all of our fellows from 2016 to 2019, about 220 of them or so, we see the knowledge score went up with a statistically significant increase. We see that there was no significant deviation from year to year during this time. Now, if we're asking the question about confidence in completing a psychiatric interview, we see that At midpoint, it was around 4. It went up to about 6 after the fellowship. And also looking at teaching psychiatric topics, the confidence increased significantly, and we were a little bit more granular with these topics and looking at pre-assessment, which is the green, mid-assessment, which is yellow, and the blue, which the dark blue, which is post-fellowship. For anxiety, we see the same with substance use disorders, anxiety disorders, somatization disorders, psychotic disorders, chronic pain management, suicide risk assessment, and suicidal assessing for suicidal ideation alone. In all of these domains, there were significant increases in knowledge and confidence of managing psychiatric disorders. This is a paper that we published last year in the Administration of Policy in Mental Health and Mental Health Services Research in summer of 2023. Title of the article, Antidepressant Prescription Behavior Among Primary Care Clinician Providers After an Interprofessional Primary Care Psychiatric Training Program. That would be the Training Trainers Program. And really what we looked at here was kind of interesting. We used one of our we worked with one of our community partners, the Inland Empire Health Plan, a large health plan in the state of California, to look at prescription pattern outcomes. And so we had a total of 40 TNT PCP alumni graduates versus about 152 non-graduates. We compared EMR data among those two groups and looked at about 19,000 patients in total of over 94,000 antidepressant prescriptions, over 18,000 benzodiazepine prescriptions, and over 32,000 opioid prescriptions total, and really looked at differences between these two groups, right? And this is what we found in a nutshell. If you look here on the left with the antidepressants, you'll see that the blue bar is looking at before the fellowship, and the yellow bar is looking at after the fellowship, post-training. And with antidepressants, we see in 2018, 19, and 2020 in particular, we did make some revisions in our curriculum in 2020, but a significant increase in antidepressants relative to the baseline for non-TNT, baseline prescriptions for antidepressants. Now, this was great to see, I have to say, because again, depression is the most common psychiatric condition. It also is the culprit for so much disability we see in this country and worldwide. And the fact that we're, recognizing our graduates are recognizing depression using antidepressants, which is first-line treatment for major depressive disorder, more frequently, and also not only more frequently than those who didn't receive the training, but also at a higher level than compared to themselves and before the fellowship. So it was really great to see this and exciting that we're able, to make this change in practice pattern. Kimberly, you have a question. Will this fellowship allow a family nurse practitioner sit for the psychiatric and mental health nursing practitioner board exam? So this program is results in a certificate of completion by the School of Medicine. So it's not it doesn't lead to certification in primary care psychiatry or licensure or anything to that effect. So it would be additive in terms of the knowledge, but it wouldn't qualify you for sitting for a board exam in particular. Now, if we look at benzodiazepines, we see that the numbers of benzodiazepine use was quite high in those who didn't go through the program. And we see that the numbers were quite high even for our learners before they started the fellowship, but significant decrease in use of benzodiazepines. Now, benzodiazepines are not bad. They're not bad. In fact, there are many reasons we should be using benzodiazepines. Benzodiazepines are very effective anxiolytics. They can be very, very helpful. The problem, though, is they also have a lot of side effects. They can cause sedation. They can be disruptive to the normal sleep architecture. Benzodiazepines can also, in some cases, cause physiological addiction. Now, I think the reason that we see a significant drop in prescription rates of benzodiazepines among our learners is because we're teaching other ways to address anxiety, other evidence-based ways to address anxiety. For example, mindfulness, right? Mindfulness coupled with cognitive behavioral therapy is very powerful and evidence-based and standard of care tool to address anxiety and depression. Other modalities, could include acupuncture, acupressure, use of supplements in some cases as well. So trying different approaches and teaching that to our fellows, I think, has been very helpful. I'm really excited to show this third figure here on the right, looking at a non-TNT use of opioids here in the blue, followed by 2018, 2019, and 2020, showing particularly in 2019 and 20, really high usage of opioids for the treatment of chronic pain, and then showing that after the fellowship, these cohorts have significant and a statistically significant decrease in use of opioids. This is important because opioids collectively are the #1 cause of accidental death in this country, right? And if we're able to make an impact and help decrease not only the emotional pain, but the often connected physical pain in a way that's going to be healthier, in a way that's going to be consistent with early intervention, that's a win. So we're excited to see that as well. Okay. Let's see if I can go to the next slide here. For some reason I'm not, but I'm going to answer a question here. Do you have to be board certified to apply? Can I apply before family medicine residency? So we would take people who are in residency, definitely, or after residency, and those who practice medicine. So MDs, DOs, and as well as physician assistants and nurse practitioners. Okay, let me try this again. Trying to advance my slides, but for some reason, not able to, and not sure why. Okay.
Do you want me to share my screen?
That would be great. Thank you, Camber. So the answer to your question is you don't have to be board certified to apply, but you must be either in residency with the approval of your program director or after residency or equivalent training as well. And it's important because in the state of California, physician assistants are only required to have 2 weeks of training, 2 weeks in training in the area of behavioral health. That's not good. Particularly if you're getting out and you're becoming a primary care provider or clinician. 2 weeks of training is not adequate. If you look at internal medicine, 3 busy years of training, there are no timed requirements for rotations in psychiatry. So oftentimes, internal medicine, let me stop sharing camera here as well. There we go. Okay. So oftentimes we'll see that with internal medicine residents, they might get some lectures, but there's no timed requirement during the course of 3 years. So that also is unfortunate. Cameron, thanks for your help with this. And so if we look at the mean antidepressant prescriptions per patient per quarter, we see that the green line is after TNT, and then the yellow line is non-TNT. The yellow line doesn't change a whole lot over the course of these quarters between 2017 and 2021, but we do see a rise in antidepressants. Interestingly, we do see it tails off a little bit in quarters 16 through 20, but other than that, a significant upward deviation increase in antidepressant use, which is what we are hoping to see. Next slide, please. So I do want to save some time for questions, actually, and after I go through this slide, and really the questions can be geared towards these TNT programs, the research that we've done and looked at, but also even talking about how we can more effectively use integrative medicine practices, and we'll also talk a little bit about a future future educational considerations and initiatives that are up and coming, and share that with you as well. But I do think it's important when we are starting a training program to improve patient care that we look at the outcomes, and we follow these outcomes as well. So this is a study that we've done just here fairly recently and submitted to the Journal of General Internal Medicine just a few months ago, and it's now in review. And it's looking at improving behavioral health disparities in disadvantaged communities as defined by the state and or the federal government. And so this is just looking at the state of California here, and of 347 fellows that practice location was available for, we found that about 90% received scholarships. A third of them practice in the highest disadvantaged area, the highest. Those really struggling the most. Examples would be the Fresno area, Central Valley, certain parts or most parts of Inland Empire, Riverside, and San Bernardino counties. But a third of our trainees are right there in the most disadvantaged areas. We're able to see an increase in the proportion of fellows practicing in underserved areas as well. And you can just see it's sort of an overview on this graphic here, and on where we're training and where our fellows come from. The area in red and darker red indicates more disadvantaged. Lighter red or white indicates less disadvantaged, or if it's white, we don't have a lot of fellows in those areas. So you can see here, the larger the blue dot indicates the more fellows we have. So for example, in San Bernardino areas or Riverside, those are dark red, and we see the larger dots there, more training in those areas, which is exactly what we're shooting for. So we hope to continue and on this path. Next slide, please. So future considerations. Now, again, when I think of pain, which is the number one reason people see their doctor, I do think of pain as being physical and emotional, which is what we've been talking about for the last 40 minutes or so. It could be spiritual pain. There's different types of pain, but they're all very similar. One of the things that we're working on at UCI, Susan Samueli Integrative Health Institute, is to build a program whereby we're training teachers with parents side by side in the areas of early prevention and detection and intervention for kids who are struggling with mental illness. Teachers aren't taught how to recognize depression or substance use disorders, or oftentimes ADHD or learning disabilities or abuse at home. And we want to make sure to provide that training. And oftentimes parents don't go to parent school. There's no parent school, or I've never seen one. And so we want to make sure that we're providing training in two domains. The first domain is to train in the areas of what behavioral health conditions look like in kids. The second domain is equally important, and that's training teachers and parents how to be better, feel better by way of whole person care and intervention, integrative medicine, and to training parents and teachers side by side on how to feel better and be healthier. We're also looking to train geriatric clinicians and doctors and expanding care in this area. There's a huge need in this space. But I want to emphasize, in September of this year, the Susan Samueli Integrative Health Institute will be starting an integrative functional medicine fellowship. We have a QR code here. If you're interested in getting more information, please take a minute to scan. This is going to be a cutting-edge, state-of-the-art fellowship that incorporates functional medicine with integrative medicine, but with the idea of building directly into general medicine, including primary care medicine. So it's not separate. It's not, this is integrative and functional medicine, and this is primary care medicine, but it's really building the two together and creating a bridge between the two, which I think makes it unique. I want to thank all of you for listening out there. I can't see your faces, unfortunately, but I do appreciate you being there. Happy to answer any questions that come up related to mental health, integrative psychiatry, the research that we've done, et cetera.
Dr. McCarron, I have a question for you.
Yes.
When the students go through this program, I know that you had some sessions like on the weekends, but are they recorded? Do they have access to it? And then what are the mentorship sessions like? Is it just kind of like Socratic method, or is there a designated topic to discuss?
Yeah, it's a good question. So, two questions. So, the first question is yes, we do professionally record our sessions, the entire session. Now, with that being said, we think it's important to have people in person. So, it's not really an option for them not to come unless there's an emergency, a medical emergency, family emergency, something to that effect, in which we'll have it recorded. The reason we want people there in person is because of the mentorship, the team building. Again, in August, we're meeting in San Diego, and we'll have over 420 fellows, but those fellows will be working in small groups with our faculty mentors, and that's where the learning really takes place. Now, the monthly mentorship sessions are really, I think, important as well. We have no slides, no PowerPoint slides during this time. We don't have lectures during this time. This time is really for the learners to talk about their own patients that they're seeing that maybe they're struggling with. And of course, they don't release the name or the medical record number or anything like that, or identifying features. But the idea is to talk about certain situations with patients that might be confusing, complex, often really, Kim, connecting the physical pain that you often see in your practice with the emotional pain, right? And that's really what we see the most. And we're able to talk in a small group about this, walk away with 2 or 3 key learning points that can be used in clinic the very next day.
Perfect. Thank you.
Yeah. Okay. Well, if there's any other questions that come up, I'm happy to address offline, by way of email or otherwise. But I want to thank the Susan Samueli Integrative Health Institute leadership and Dr. Malik and Kim Yu as well for allowing me to talk a little bit about this. I think it's an important topic. I'm biased though as a psychiatrist, but I think it's important to talk about mental health and how we in integrative medicine, in the integrative medicine specialty, can make a difference in this area. Thank you very much. I appreciate it.
Well, thank you everyone for joining us today. Our team will email all registrants the link to this recorded session. We hope that you can join us at our next research webinar on July 17th with Dr. Jeffrey Dusick, the Susan Samueli Integrative Health Institute Director of Outcomes Research and Professor in Residence at UCI Department of Medicine. Please look for an email to register, or you can visit our webpage linked in the chat. Thank you again, and see you next time.